I'd like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
Hi everyone, and welcome to the November 2018 edition of the PRS Journal Club podcast. I'm Ira Savetsky, PRS Resident Ambassador from NYU, and as always, I'm joined by my co-resident ambassadors, Francesco Egro from the University of Pittsburgh Medical Center, and Nicole Phillips from the Harvard Plastic Surgery Program. Today we have the great honor of being joined by Dr. Matthew Hanasono, Professor and Reconstructive Microsurgery Fellowship Director in the Department of Plastic Surgery at the University of Texas MD Anderson Cancer Center. Thank you so much, Dr. Hanasono, for joining us for this PRS Journal Club podcast.
Thanks so much for having me.
A quick reminder, all of the articles that we will discuss can be read for free on PRSjournal.com, including an archive of all past Journal Club articles. The article we'll be discussing is The Architecture of Fat Grafting, Part 2, Impact of Cannula Diameter, by senior author Dr. Peter Rumud from the University of Pittsburgh. I chose this article because while the applications of fat grafting continue to broaden in both aesthetic and reconstructive surgery, there still remains an element of uncertainty with regard to retention, often necessitating patients to undergo multiple operations to achieve the desired result. There are a multitude of technical descriptions on how to harvest, process, and transfer fat without a consensus as to which is most optimal for maximal survival. In general, to achieve maximal adipocyte viability, emphasis is placed on minimizing trauma during harvest and processing of fat and depositing fat in small aliquots. The authors have previously shown that the volume ratio of transplanted fat to host tissue significantly impacts the percentage of graft survival. Graft that is placed greater than 2 millimeters from native blood supply will undergo necrosis. Therefore, an improved understanding of the architecture of fat within the recipient bed is critical to improving outcomes. In this study, the authors hypothesized that the diameter of the cannula used for injection can impact the fat graft tunnel width by altering the size of each fat parcel and by affecting the precision with which parcels can be delivered. The authors studied the architecture of fat placement following injection with different sized cannulas. In terms of methods, harvesting of fat was from Pannis specimens performed using 4 mm Mercedes cannula. Lipoaspirate was then stained with methylene blue. The fat was processed by centrifugation for 3 minutes at 1200 Gs. The aqueous layer was decanted. This blue stained fat was then injected into standardized locations within Pannis sections using 12, 14, 16, or 19 gauge Coleman cannulas with a single aperture near the distal end. Each cannula was assessed at 3 different volumes, 0.1, 0.5, and 1 cc to determine if the volume injected per pass affected the diameter of the parcel deposited by cannulas of each gauge. The specimens were then frozen and sectioned and the architecture of the fat deposit were analyzed. In terms of results, with an injection volume of 0.1 cc, no fat deposits had a radius greater than 2 millimeters regardless of cannula size. A graft volume of 0.5 cc created globules greater than 2 millimeters with larger cannulas, 0% with a 19 gauge, 2.9% with 16 gauge, 6.1% with 14 gauge, and 4.3% with 12 gauge. Injecting 1 cc resulted in a significant increase in the percentage of fat parcels expected to undergo central necrosis, 16% with a 19 gauge, 21% with 16 gauge, 26% with 14 gauge, and 44% with 12 gauge. Overall, I thought this was a really interesting study. It again highlights the high quality fat grafting and optimal retention depends on multiple factors. Now, this was the first study to examine the impact of injection volume and cannula diameter on the architecture of fat graft within the recipient bed. The authors conclude that the optimal volume retention can be achieved with a 19 or 16 gauge cannula if 1 cc is injected per pass, and that all fat will be placed within 2 millimeters of host blood supply if only 0.1 cc's of fat is deposited per pass regardless of cannula diameter. One thought that I have, and I'm curious to hear everyone's thoughts, is while the size of the cannula can certainly affect the final diameter of the cylinder of fat graft in the bed, if one was to adjust the distance traveled while injecting a fixed volume, this too, I would think, would determine the final dimension of the cylinder and ultimately graft success. For example, if you just inject a large bolus of fat without withdrawing your hand or moving the cannula, you would have a very large diameter in a particular area, and vice versa. If you were to withdraw or move the cannula quickly over a large distance, you will leave a very small diameter cylinder. Therefore, I'm not entirely convinced that cannula diameter matters as much with respect to the diameter of the cylinder alone. Certainly other factors are important, such as shearing and any trauma may play an important role. Dr. Hanasono, I'm curious to hear some of your thoughts about this paper and some of your preferred techniques for harvesting and processing and injection of fat grafting.
I commend the paper in that it's enlightening for me as a clinician to realize the outcomes that they show, that both the bore size of the injection needle matter. But as you point out, I agree. I think their test specimen size was 4 centimeters, and as you know, there's different length cannulas, and you can kind of push and pull a little bit as you inject, and so I think it's more frequent that I'm injecting quite a longer distance. So, I would just guess somewhere between 6 and 10 centimeters per pass. So you can't just take the numbers that they give and use them exactly. And then, as you said, also the speed of the pass, how quickly you're moving the needle, certainly should have an effect on the diameter of the cylinder of fat that you leave behind. So a couple variables that I think the casual reader of the paper should be aware of rather than just taking the numbers that they give. Another thought I had was that we often overlap passes, and we don't clinically have a way to make sure that one injection and then the one done next to it, that we're not really going through the same tunnel. I'm sure that can happen as well. So in the end, you may not really be getting pure cylinders clinically, but rather meshwork and many overlapping areas, so you won't necessarily get that nice clean cylinder where everything is within 2 millimeters of a vascularized wound bed.
Yeah, I think those are really great points, and yeah, I think while we like to sort of perceive these tunnels that we're creating are perfect, I agree that we're probably oftentimes getting into the same region. Francesco, you're from University of Pittsburgh. I didn't think I saw your name on the article, so I'm curious to hear your honest opinions about it.
And I also just spent 1 year with Dr. Rubin and Dr. Mara in the labs. So, all the authors are my friends, co-residents, and I really feel left out. And of course, as someone who spent 1 year in Dr. Rubin's lab, I have to say that this is the best paper in the world, first of all. But I'll also confirm that we love fat in Pittsburgh. Jokes aside, I thought this was a very elegant paper. It gives us a great idea of the effect of injection volume and cannula size on the architecture of fat graft within the recipient bed. And it's kind of a basic science project where it's to a certain degree clinically relevant, but just like Dr. Hanasono was saying, you might be doing multiple passes, and so whilst you might have a perfect cylinder, if you do multiple passes, then that can influence. But I think this paper gives us a good idea, however, of how much volume per cannula size we can potentially inject. This knowledge hopefully brings us a step closer to optimization of the fat grafting process, and which hopefully one day will lead to as close as 100% take as possible. I think that Dr. Rubin and the team bring up a key issue where you have, on one hand, we have larger diameter cannulas, which may decrease shear trauma to cells and improve adipocytes' viability during the placement of the fat, and are great for larger cases like breast recon, where you have to inject lots of fat. But then we have smaller size cannula, which may allow for more precise placements of fat deposits, near the native blood supply, and therefore promoting greater engraftment and survival of the fat. So you have this kind of dichotomy, smaller cannulas has some benefits, larger cannulas has certain benefits. So Dr. Hanasono, my question for you is, where do we find this balance? And is it about tailoring the appropriate technique to each patient's needs?
I was thinking about this. The paper does a nice job of discussing some of the various clinical considerations. The argument to use kind of this medium of the middle diameter cannulas and do very small micro droplet fat grafting makes sense. In my mind, kind of the small to medium volume fat grafting session, if you're trying to make a major difference, for instance, in breast or buttock augmentation to the point where the patient can see a substantial difference, it makes me wonder whether you can really inject enough in a single session to complete the final transformation in a relatively reasonable number of surgical procedures. In other words, I think if you're injecting microdroplets and being very careful to not have the tunnels or cylinders created touching each other, and for everything to be within 2 millimeters of a vascularized bed, you may be limited in how much you can inject into a given area at one time. I think most patients would be happy to have a procedure that's only done once, and I think most of us warn them that fat grafting is probably something that you might need 2 or 3, sometimes 4 repeated procedures on. But I think it just makes me wonder, the logical extension is if you really want to balance, get really good graft survival, perhaps to follow these rules, you might end up needing 6, 7, 8, 9, 10 procedures, and I think that would be unacceptable to patients. Conversely, I do breast reconstruction, but most of my clinical focus is on head and neck reconstruction, and we recently published a paper on head and neck fat grafting, and here the problem is that the areas are very, very small, and particularly in my head and neck cancer patients, the spaces are very, very tight. So it really is impossible to inject any sizable quantity of fat without getting the sense that all the grafts are somehow in communication and touching with each other.
So it's a matter of trying to tailor to the patient's needs, I guess. And so we do quite a bit of head and neck here as well, and I totally agree with you. I've been with Dr. Rubin and doing these cases where we do breast recon cases or we fat graft the larger areas, and that's much easier to inject versus the head and neck cancer patients. They're just so challenging, and also depending on the size of the particles that we inject, there's going to be more or less necrosis. So, and also I wanted to say that I agreed with Ira what he was saying with the multiple factors that affect the fat grafting survival. But hopefully this paper is bringing us a step closer to maximize this fat graft survival. Nikki, what did you think about the paper?
I agree. I think there's a lot of challenges that have been highlighted here. And, one of the things that the authors alluded to in the paper themselves was in large volume settings, such as, for buttock augmentation, which has certainly gotten a lot of interest recently, some of these findings just might not be practical. And so I think we sort of have to take the lessons we're learning here and apply them in different ways and sort of think about it, for future studies. Dr. Hanasono, one of the things that I am thinking about as I'm, about to go into practice myself is really the question of just how do I counsel patients about fat grafting? I feel like to some degree, these studies are proof that it's a little bit unpredictable still for us, how much, exactly of the fat we expect to take. And I just would love your advice on how you talk to patients about it, how you, manage their expectations with regards to fat grafting.
I warn all patients up front that fat grafting is usually a multi-stage procedure, and that my typical patient does not achieve the results, even in small volume fat grafting on the face, in a single session. And that's one thing I tell them. Certainly tell them that it's minimally invasive and that it's been a real game changer in reconstructive surgery, and that, oftentimes we were doing big pedicled and free flaps, and we get the result that we get. If we overcorrect, that was always much better than undercorrecting. We could always do liposuction or direct excision of fat and skin to improve our contour, but if we ended up with concavities or not enough volume, patients were out of luck unless they were willing to undergo a subsequent free flap or a pedicle flap procedure. So I do tell them that this is a wonderful thing and that it does require many stages. I warn them that oftentimes the first stage after the first fat grafting treatment, that they may be disappointed in that the results that we achieve will be limited, the correction, but to kind of have faith in patients in that ultimately, almost without fail, patients succeed quite well, provided they're willing to undergo multiple procedures. I would say the one patient group that is more challenging to achieve those results is in some of the more advanced head and neck cancer patients who are cachectic. I've noticed that these patients struggle to keep weight on their bodies, and the problem for me there is, one, it's hard to find fat anywhere on their body to use as a graft material, and two, if they continue to lose weight, it seems to me, just subjectively, I haven't done research on this, but the fat graft is one of the first places they lose weight, which kind of holds true in general with all of our bodies. We always seem to lose weight where we don't want to lose weight, and then we pick up weight where we don't want to pick up weight.
Absolutely. Thanks very much for your thoughts on that.
Ira here. I think those are really great points. We recently just had Dr. Tim Martin come as a visiting professor, and he spoke about his techniques for fat grafting for the face and with his facelift. And when you listen to somebody, we get to spend some time with Dr. Coleman and physicians who are fat grafting a lot. It's incredible how much thought is put into it, and the ones who are really masters really take the time and analyze all these different factors. And I think there's so much to learn about this. One thing that he mentioned was that he starts his case, if he's doing a full face and neck lift, he'll start with fat grafting. And the reason why he does it is because he thinks it requires so much attention to detail, and he feels that if he goes and does the face and neck lift and then you do the fat grafting, you're gonna kind of rush in and maybe be more careless. And I thought that was a really interesting point. And it's nice to see papers like this really going through the science behind it. I think with that, we'll end our discussion of this article. Thank you, everyone, again, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us in the Apple iTunes Store. Also, remember to tune in to the other 2 articles that we'll be discussing on this month's podcast. And finally, please join us this month for our monthly Journal Club on Facebook, where we'll be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not yet done so already, and it is there where our monthly Journal Club takes place. And once again, thank you so much, Dr. Hanasono, for joining us.
Thank you so much.